I'm Dick Moberg, and welcome to our interview series. A lot of interesting people pass through our doors who are doing amazing work in brain monitoring. We bring them into our studio, put a mic on them, and get the personal stories you don't normally hear. We hope you enjoy them. Hi, I'm Dick Moberg, and my guest today is Dr. Julian Bösel. And I've known Julian for a long time, and he happened to be in Baltimore, and we got him up here to our studio. So thanks for joining us.
Thank you so much for having me.
Yeah, it's a real treat. So I wanted to, we were talking actually at lunch about, you're one of those people that I think I've known forever, but we were trying to figure out where did I meet you, and it's probably back in Philly at that multimodal monitoring conference. May have been the first time.
I don't think so. I think we certainly before that.
Right. Well, it's been a long time, and Julia's been a great friend. Lives in Germany, and when I was over there, I used to go to Heidelberg a lot, and I'd stop in, and he showed me one of my favorite bars. Do you remember which bar that is?
That must have been the Schnitzelbank.
Schnitzelbank was the favorite restaurant.
Yeah, right. And the famous bar was the distillery.
Exactly, right, exactly. And I go to that bar every time I'm in Heidelberg.
Wow, great.
And Schnitzelbank. So
very good.
Thank you for those little gems of my life.
No problem.
Cool. So I wanted to, I want our listeners to get to know you, and I want you to tell them how did you get into neurocritical care? I mean, what led you, of all the possibilities of a career, what led you to neurocritical care?
Right, yeah. Let me just quickly say who I am or what I'm doing now, and then let's see how I got there. Yeah. I'm currently a professor of neurology at the University Hospital Heidelberg, but also an adjunct professor at Johns Hopkins Hospital in Baltimore. I'm also the immediate past president of the German Neurocritical Care Society. So you see, I'm pretty involved with neurocritical care, and now the question was how I got there. And it must have been during my specialization to become a neurologist. That was at the Charité in Berlin. It may have been around 2005 or so when I did my regular rotation into neurocritical care. That is a part of any neuro specialization in Germany. And that's when I entered the Charité Neurocritical Care Unit. And it was a great place. It was especially a great place for looking at diseases like myasthenic crisis or really bad cases of encephalitis, and also Guillain-Barré syndrome. So those would be the things that I would encounter first. But the problem was that the neurosurgical department was in a different place in Berlin. It was not in the same setting on the same campus with our neurocritical care unit, and so that was when I really got a taste of the field and got sort of interested. But I also saw that with really dealing with more catastrophic diseases, I would have to go somewhere else. And so later, after finishing my neuro specialization, I went to Heidelberg, where I had also studied. And there I continued to work in the neurocritical care unit that was set up there by Werner Hacke, who was my clinical teacher and sort of raised me and really got me deeply into neurocritical care. And that was a place where you really had the full spectrum, and it was a university hospital. It was a unit that was entirely run by neurologists. So neurologists would do everything, yeah. And that gave me the opportunity to really explore the whole field, and that is where I also found my main interests in clinical medicine, in research, it kind of stuck with me till today.
Yeah, Werner Hacke certainly is a well-known person to many people in this area. I think he pioneered hemicraniectomies, or at least popularized that procedure. That's what I know him for.
Right. Yeah. He's certainly one of the most important stroke neurologists, yeah. And he has done so important trials with regard to thrombolysis and other forms of acute therapy, but also with regard to hemicraniectomy.
Yeah.
And he would, neurocritical care would really be one of his most beloved fields in neurology. And if you worked in his unit, you could sense this fascination and the support that he had for it. And it was also, he also taught us that neurology, yes, it's a nice intellectual thing, and you can contemplate a lot, but it is also a field where you can do something and act, and particularly with regard to neurocritical care. So the neurocritical care that Werner Hacke developed and that he then taught us, that was the neurology of acting, and really see the effects and do something, not be hesitant, but rather go for it. And that's what I liked.
Yeah, I also know him from some parties in Heidelberg where he, I think he has a love of heavy metal music, doesn't he?
Absolutely. He's a fan and an expert.
Yes, yes, which was interesting for me to find out. Yeah, you know, another thing I learned in, I think it was in Heidelberg, where I first learned one of the differences between U.S. and Europe. And in Heidelberg, I remember one of the early times I visited, I was going into an ICU. I think as you get off the elevator, it went right, and there was a door, and it was the neurological ICU. And then somebody said, oh, well, there's also a neurosurgical ICU. And in the U.S., we don't have that really. What's the difference there? And maybe just in a broader sense, how do you see things different from the U.S. and Europe? But that's one thing I've noticed in Europe, that's they separate those.
Yeah, well, not everywhere, but it is certainly, I'd say the landscape of neurocritical care units is much more heterogeneous than it is probably over here. So here you have a neurocritical care unit or a neuroscience ICU, where you would find patients from neurology, patients from neurosurgery, and you would also have this entity, the specialty of the neurointensivists. Yeah. So to start with, we don't have that. Yeah, we have neurologists, we have neurosurgeons, we have anesthesiologists, and they may have an extra qualification in neurocritical care. That is not the same as having this as a full specialty. And along with that, it goes that we have very different formats of ICUs for patients with these diseases. So you may have a dedicated neurological ICU that is led and owned by neurology. You may have a separate neurosurgical ICU led and also owned by neurosurgery. You may have very few combined neurological, neurosurgical ICUs, very few, maybe only 10 in the whole country or so. And then you would have the large majority of certainly 80% of larger interdisciplinary ICUs, often led by anesthesiology or internal medicine, and neurologists or neurosurgeons would then have the option to put some of their patients there, yeah, and would rather be a consultant service for these ICUs. And that is the situation in Germany. And in terms of comparison, it is quite a challenge, for example, in terms of education. Yeah, because all young neurologists and neurosurgeons have to learn neurocritical care, and it's not too easy to realize that in Germany.
Mm. And so in one of these consolidated ICUs, if you had to do some advanced monitoring, like ICP, or if they're doing brain oxygen or microdialysis, who does that, or who would be responsible for that?
Yeah, that would be for the most part the doctors who are doing the service there, the rounds. Yeah. Sometimes for some of these neuromonitoring things, you would have help from technicians, but probably in most places the machines would be down there in the unit, and then the doctors would set them up and measure and interpret what is going on. And again, the degree and the choice of neuromonitoring devices would be very different from place to place.
Well, we find that in the U.S. too. I mean, when we were involved in all these trials, every hospital's different. I mean, they may use some of the same monitors, but then something else is different. And, you know, that's one of the things that I think has plagued this field, is that just the diversity of how care is given and the devices and all that made it hard for us.
Totally. I think in many countries and within many countries you have very different approaches. So that is also a reflection of that we do not have standards for many approaches, and we still don't know what is the best way to monitor the patients. And so people do it very differently, and it also has to do with personal interests, with research projects, and also with customs or habits that have been traditionalized in those places. And it would certainly not be bad to approach maybe a more standardized way, but for that we need more data.
Yeah, and we like data.
I know data, and you guys, I mean, you have been around. So he's in the beginning. He said he knew me forever. I can say the same thing. So if you have an interest in neuromonitoring, there's no way around Dirk Moberg. So I have the feeling I know you since I'm interested in neurocritical care, and you have followed all the steps and developments with that, and now you're tackling the big data, and it's just amazing what you do.
Well, some people say there's something wrong with me, so it's one or the other.
There's a nice song by Joss Stone. It's the title is I've got the right to be wrong.
Or the right to be crazy, right?
Exactly, the good crazy.
You know, I think there's something interesting in what you said, is that you think that there is no like neurocritical care specialist in Germany, but what we were talking about is the DGNI is older than our neurocritical care society in the U.S., and that's pretty cool. So you guys formed a group way before they did in the U.S. to focus on this, and you were the past president of that organization, right? Why don't you talk about that a little bit? How did that form, and what does it do now?
So the DGNI, Deutsche Gesellschaft für Neurointensiv- und Notfallmedizin, which means the German Neurocritical Care and Emergency Medicine. You are right, it was founded in 1984. For example, by Werner Hacke and a couple of other guys.
Cool.
What they did from the beginning on, and I think that was the most important thing, was they got everyone at the table who was involved, meaning doctors and nurses and therapists. So everybody who worked there, the interdisciplinary team, would be invited to make up that society, and so even today in our annual meeting, all those professions would mix. That was a very important thing, so the DGNI has quite some tradition. Back then, in the beginning, it was the name was ANIM, and later ANIM was only the name, or was used as a name for the annual meetings of the DGNI. So that's ANIM stands for the A stands for Arbeitstagung, which means working meeting, meaning that this is not a conference or congress in the traditional sense, but it's really getting together and working together on some questions. And the ANIMs kind of have kept that atmosphere, of getting together and really sort of exchange. Often in a very informal way, uncomplicated way, and tackle the problems that we're dealing with. It's been around even longer than the NCS, but then the NCS, I should say, has overtaken us in many aspects. They have had a wonderful development. So we are the societies are really befriended, and we are very happy that we started in 2013 with joint meetings you remember Mannheim, yeah?
Absolutely. I
Yeah,
had a lot of fun
science,
at that meeting. That was
science and culture and
Yeah.
party, I should say.
Yeah.
And then we did another nice one in Würzburg in 2018,
Yep.
and we will have our third one upcoming at the next
February.
Arnhem, February. That I have the pleasure to be conference president, and that will be in Kassel in the middle of Germany, and we will have our third joint meeting with the NCS there.
Yeah.
And I'm looking forward to it a lot.
Yeah, me too. That's good. I think the ANA meetings was one of my favorite, even though a bunch of it's in German. I go to Germany for science and beer,
And schnitzel.
and that takes care of the science part, right?
Right. Very
So
good.
it's been a lot of fun, and they're great meetings. Just to see friends that are there from all over the place.
Right.
So it's a great meeting. So what do you what do you see, having been in neurocritical care for a long time, from your perspective? What do you see are the challenges that you'd like to solve, and what do you see as the future? I mean, where do you want this field to go, and what are the barriers we got to overcome? I know we've talked a little bit about those, and I think you have a pretty good perspective on that. But and where do you want it to go? What would you like?
Right. Well, I mean, what we have seen and what we have what we have also proved, it has been shown in studies, and that I think is really a difference to other ICU fields. Yeah, it has been shown that this package of dedicated neurocritical care really has an effect. It really improves morbidity, mortality, research destination, and you name it. So we are pretty certain that this whole thing is very good for the patient. It works, yeah. Although we still don't know exactly which part of it are the most important bits, or which part maybe even not relevant, yeah. And we have to continue to work on that more to find out what is really the quintessence of it. I think what we have to do more is, for once, really go from retrospective research to prospective research. Yeah, it's really important to do more and more prospective studies. And of course, it would be great to do more randomized trials with that are outcome directed. And we have looked at a lot of surrogate parameters like physiology parameters, but we really have to look more on clinically important endpoints, and maybe not only the classical ones like mortality and survival or functional outcome in the terms of the Rankin scale, but also on cognitive outcomes, for example, cognitive performance, quality of life, outcomes that have to do with family and caregivers. So these things I think we should look more at. And the other thing that I would say are important are that we have seen a couple of nice studies and trials on single measures within the whole spectrum of measures that we can undertake to help this patient, and quite often these trials and studies came out neutral. Yeah? And I guess that these diseases are so catastrophic, complex, and have so many factors and confounders coming in that we may have to aim for a stronger effect size by combining measures. Mm-hmm. Yeah, so maybe look at bundles, a bundle of 2 or 3 measures instead of one measure only. And there I could see some potential. And the third great potential and the way forward I clearly see in everything that has to do with big data. So big data, AI, machine learning, that would really be the way forward, no doubt about it. I think it's really not a question if we need it or should do it, but a question how quickly, or what are the studies, where are they directed, what are the outcomes that we would be interested in. So because the ICU I think is the ideal setting for that kind of approach and that kind of research, and it could even help to overcome the hurdles that we face. You were asking about the obstacles in neurocritical care, and at least in Germany, and probably I could even speak for Europe, these are staffing. So a lack of doctors, a lack of nurses, an overall tendency in healthcare administration to go from specialization to generalization and try to condense everything, to fuse everything, to save money. Yeah, and so we need new and creative ways to overcome this or to help with that. And new technologies like AI or also telemedicine could be helpful there.
Oh, that's very interesting. Yeah, I think that I know that just to go back to one of your points, I mean, being involved in a lot of these trials and looking at data, the confounders, I think, outweigh all the other things. I mean, I personally don't see how TBI trials can be conducted just because there's so many things that alter the data that aren't recorded. We talked a little bit about that today, and boy, that's why we're trying to figure out how can we help that by just, I mean, at one point you want to get massive amounts of data, and then eventually you want to get a lot less. You want to pare it down to what you have, but boy, there's a lot of challenges. I think in this field.
Totally. I mean, obviously the best way to level out the confounders is randomization. Yeah. But then you cannot always do randomized trials. And if you talk about data research, you would have to find other creative ways of picking up those confounders. And one important confounder that is clearly neglected is the role of nursing, for example. Exactly. In my opinion, the nurses or the nursing in neurocritical care is probably be among the most important, if not the important bit that has to do with the well-being and the course of the patient. And so what nurses do with the patient can probably be good, or it may also sometimes be bad, depending on how it's done and when it's done. But this is almost never picked up. So we do all our studies, but we kind of turn a blind eye on that part. Although I'm convinced that it's very, very decisive. Yeah. Mm-hmm. But we don't document it. We don't look at it. So. Right. We should really think about ways to incorporate that. It would be very important, I think.
No, I'm 100% agreeing with that. I think their role is key to some of these outcomes. So, yeah. Anything else?
How's your sailing doing?
Well, I want to, would you mind getting that little T-shirt over there on the table? So Olivia's here in the studio with us, and thank you. Cool, all right. So you probably remember this, right? So on one side is the Neurocritical Care Society.
Yeah.
Right? And called Controversies in Neurocritical Care.
Yeah, hardcore research.
Now you would think that this was from a scientific meeting, right?
It was.
Well, it kind of was.
It kind of was.
It was business, but it was business that we call monkey business, all right? Because if you look at the back, all right, this is a sailing trip that I think you helped organize, and Cheryl Chang, I think, and a couple others.
Right.
And I really had the pleasure to be aboard Julian's catamaran for this trip, this official Neurocritical Care Society trip around the British Virgin Islands that we were talking about, how we went around, and in the daytime we sailed, in the evening we all got in our dinghies and went over to the back of a huge boat that Michelle Torbay had, and gave talks. And it was a really, really nice mix of fun and science, and probably one of the best trips I've ever been on. And
I'm glad to hear that, and I totally enjoyed it myself.
Yeah.
And we actually, for the talks in the evening, we had one particular rule, and the rule was it must not be boring. So everybody had to pick a topic that the others would not have heard about, or that were kind of special. And I really have to say, all those talks were really, really good.
Yeah.
Really good. And the drinks afterwards somehow tasted better than than without the talks. Yeah. And no, I remember we had a really good time on board our boat.
I think we had a special boat. It was good.
Certainly, yeah, and that was also because of you. Yeah, I think you among the crew you were the most experienced in terms of life experience. So we kind of I think we sometimes called you Mr. President when you came to the deck. Yeah, and so we said Mr. President, and then you said you may be seated.
Yes.
Yeah, I remember that. Yeah. No, we had a lot of fun. It was a great combination of fun and science and. Something that is also very important in that part of medicine is working as a team, and that was also reflected in that cruise, I think.
Yeah, no, it's a really special part of my life, and I'll always remember that. And I've been back a few times, so
great.
Really cool.
I'm very glad to hear that.
Well, thank you again for coming up here and visiting us.
Thanks for having me.
And I hope you'll come back to beautiful Philadelphia.
I have to. I just learned that in this building the famous Stetson hat was made.
Yes.
And then I heard that this area is the greatest anyway. So I guess I have to be back.
Yeah, good. Well, I hope you'll join us
in
the future. Good.
Thank you.
Thank you.
Thank you.
Cool.